Hi, everybody. I hope everybody's doing okay. Um, we're doing a self-quarantine question and answer today. We have the privilege and honor of having my dad here again. And as you all know, he's a clinical psychologist in private practice with over 40 years of experience. Has published extensively in the field of hypnosis. And today we're going to review the article titled Three Failures of Direct Suggestion and Psychogenic Dermatitis Followed by Successful Intervention. And what I was thinking that we'll do is we'll jump right into the questions that you guys emailed me, and I'll have my dad provide his responses. Question number one is, are there different techniques of hypnosis that you could use to prevent flare-ups of different skin conditions, or is there only one type of hypnosis?
This is a very important question. First of all, let me say that I'm honored and great to be here. It's a pleasure to present before you. The question of specificity that comes into mind here, and it to the degree that we search for greater specifics, the answers dry up. There is very little published in the field from an empirical point of view. Most of the available data and results are anecdotal, but the question bears a response, and that is that no, there's no degree of specificity in terms of the clinical strategies employed according to the nature and extent of the symptom. Here, you saw that initially the technique in place was a direct suggestion under hypnosis. There I make reference to the patient's ideations of a cool balm, and we use the same thing. I personally use the same thing every time I employ a direct suggestion under hypnosis. But the important point, and it's an offshoot of what you asked, is that the principle of parsimony has it that I started off with the most simplistic and the least penetrating, let me put it this way, the least invasive method, and then we failed miserably, and then came back and found success when we tailor-made the procedure to the patient's needs. And here's anyway, I want to talk about the importance of formulation, because you indirectly hinted at that, and the specificity and the minuscule, even the most minuscule data falls under some type of formulation. So we'll put that aside, and maybe it'll come up again, and they'll deal with it more profoundly if we have other questions that come into that part of the neighborhood.
Okay. So another question from a student is, can Dr. Iglesias give some specific examples of the techniques of ideomotor questioning he used?
Yes, of course. I adapted my approach and my model to Ewing, who's a giant in the field and somebody that I trained directly under, and listen to the indirect nature of these questions, and they're intended to reach the subconscious mind with the least bit of opposition from that valuable organ. First of all, with the patient in hypnosis, I ask the patient, is it all right with your deepest mind for me to help you with this problem? And that's a very important question, because it strikes at the heart of opposition, of resistance. Another question that is very important, and it reaches the deepest recesses of the issue without triggering a lot of involuntary opposition. Is it all right for you to know why you have this skin reaction? That's a very important question, because it hints at the opportunity and the possibility of helping the patient without them knowing how the results came about the way they did. So if you have a patient who says, no, it's not all right for her to know why she has the skin reaction, you're blocked. You can't do any further exploration, because the insight is what the patient is trying to avoid. So you have to go about it with a great deal more of casual and metaphors and incidental and roundabout ways.
Right.
And when I count to 3, the problem will come to your mind. And by the time you say that, you have already received affirmative in the previous questions. So the patient is telling you that it's okay for the problem to be exposed, the problem to be exposed to her conscious mind.
Okay. The student also wanted to know why did these self-protective mechanisms, i.e. the psychogenic dermatitis, developed by the unconscious mind, were relocated to the index finger of a non-dominant hand only, and not to another less exposed and small body part, such as a toe, for example.
Well, there's a very, very profound and very important reason why I did that, because that's what Dr. Cesar Doty employed in his approach. So I'm not to be credited with anything profound or marvelous. It's just that
Right.
I followed the approach that Dr. Cesar Doty.
Gotcha.
With his approach, I adapted mine to his.
Okay. This is a question regarding case number 3. Let's make sure everything's okay with the videotaping. Yeah, we're okay. Good.
Case
Okay.
number 3.
Case number 3. The question is, after hypnosis, was the patient then consciously aware of the abuse she had experienced? Or was that something she could only recall under hypnosis?
And this is the case of the patient who was abused repeatedly by an older sibling. And it was done by a brother.
Mm-hmm.
The question lies in whether insight was provided for the patient.
Right.
Yes, there was insight. There was insight. I don't go at length into it in the article, but a degree of enough insight was retrieved in order to have the patient be in accord with the direction of the treatment.
Right. Okay. This is a more general question. Is there a certain age group that reacts better to hypnosis than others? And if so, what age best reacts? And which age does not react as well?
Hypnosis is applicable in every age group. We have the understanding that the younger set are more amenable. They're more trusting. They're less complex in their symptom and resistance formation. But you, with that in mind, you have to stage the induction to fit the age group and not only the age group but the formulation to fit the treatment as closely as possible to the needs and the permission that the patient provides you.
So it sounds like there's developmental considerations.
Yes, but there again, just like my response to the first question that highlighted and that made emphasis on the fact that we don't have specific data. We have mostly anecdotal and
Right.
case studies.
Right. So this question is, that the direct suggestions were ineffective in the 3 cases of psychogenic dermatitis, but Ewan's model with sacerdotes technique was effective. Are other psychogenic diseases besides dermatitis better treated with Ewan's model with sacerdotes technique? In other words, can this technique be applied to other psychogenic diseases besides dermatitis?
Yes, it can, and we have an article that was published subsequent to the one that we're reviewing today, wherein I treated. Well, it was a cursory treatment. It was a treatment that was developed as a result of the material that we obtained from the hypnotic session, from the hypnotic induction session, and then we instituted institutional mobilization. There's a very interesting case of a young Hispanic that I saw for a consultation at the Juvenile Detention Center in Miami, who was one of the most, if not the most, bully and the one with the greatest swagger and the most expressive of his sexuality and of his physical prowess, who was spending a few days at the Juvenile Detention Center in Miami. Something very, very strange happened. At the conclusion of the recess time, and when everybody was ordered back to their units, he was unwilling. At first, it seemed like he was unwilling. Then they realized that he was unable to ambulate, and so they carried him to the medical unit, where the physician on call did a neurological pain test, and he determined that the person was truly anesthetized, had hypnoanesthesia. And so I was called in to do a consult, and I did a hypnotic interview, and he was able to walk without a problem. So I did some institutional questioning, and I found out that he had been scheduled for a transfer to the most violent unit, and he was truly and patently terrified, except he couldn't externalize it through adaptive means.
Yeah.
And so instead he developed hypnoanesthesia and paralysis, conversion disorder, motor. And so when I determined what to do, I spoke with the superintendent, and we came to the conclusion that the best thing would be for him to be instructed that he was not about to reach the level, the unit number 5, and so that's what the superintendent did. He made an announcement to the entire unit that all further admissions would go to, and they routed them to a more peaceful unit. Within 20 minutes, he was walking, and he was ready to go back to his unit. That was an institutional adaptation
Yeah.
based on the
Yeah.
findings from a consultation with hypnotic questioning.
I'll make sure and post that article for you all to review. It's very interesting, and I think you would enjoy reviewing that article now that my dad's referenced it. It's really cool. This student asks, has your father ever encountered a case where the flare-ups return in full force after having been treated successfully?
No, I haven't, to be honest with you, but I really haven't treated that many of these cases. We have been fortunate to have the ones that we have reported on, but there are psychologists who have more experience, they have seen more cases than we have.
Right.
Because of the fact that they may be hospital-based, they may be working for a clinic, and so the volume is greater.
Right. The student also wanted to know if you've ever used hypnosis to stop something called body-focused repetitive behaviors.
Is that like a restless leg syndrome?
Could be. I've never heard of it.
I've never heard of it either.
How would your father approach treating this type of behavior through hypnosis?
Well, I would recommend to do the same thing that we did here. Start out with the least invasive, and then proceed to the more invasive the domain.
Right.
If you're able to curb the behavior by direct suggestion under hypnosis, then you're ready to return the patient back to his primary. If not, then you have to inch your way in and
Yeah.
do more of a exploratory.
This student wanted to know if there's any specific ethical guidelines for suggestions that are given while subjects under hypnosis. One of the patients had admitted to participating in group sexual activities in college, and as a result, it was decided that the reaction of itching out to remain in place on her index finger as a reminder. How does one tell whether a hypnotized subject is willingly giving consent for their treatment if they are in such a vulnerable state?
Boy, that's a very important question.
Yeah.
I don't have a global answer, but I approach it from a unitary point to a more expansive area. I can't say enough about the importance of formulation, because formulation gives you the entire spectrum of knowledge about this patient, and you can then envision treating them to this goal or to this objective, or treating them to the same goal or the same objective in a disguised way. But you have to secure informed consent. I do a psychoeducational session, the first or second session,
Right.
where I instruct the patient on the likes of hypnosis,
Right.
the definition of hypnosis. We do an extensive review of the misconceptions, and then I also like to involve the patient in knowledge about the applications of hypnosis. So they have a global idea as to what
Right.
what the treatment, what direction is going to take, and I have the patient always aware of the fact that if he or she lifts the index finger on the ideomotor signaling hand, that means that the direction has to be altered. They have to be rerouted to their safe place. So the patient always has a button to push. Like if you fall in your treadmill, you know that automatically shuts the treadmill off. We have so something akin to that.
I thought you were gonna say it was like one of those buttons like in a James Bond car, and it ejects you from the vehicle.
Oh yeah, well, it goes without saying.
Yeah. Okay. What if the patient during the reframing process does not acknowledge the root of the problem causing acute neurodermatitis? What would be your next steps? And I think you alluded to that earlier, that it halts that pathway.
That's correct.
Yeah.
We would then be obligated to pursue it. First of all, to review it with the patient, and then proceed from that point on to in a different direction. We have choices. We can pursue symptom diminution.
Yeah.
With insight, the symptom diminution without insight, or then you can select another mode of treatment if that the direction is closed off to you.
Yeah.
But we wouldn't be. I don't think we would be shocked we wouldn't be shocked or be exposed to the dramatically opposite results than what we envisioned, because we're asking the patient, is it all right with your deepest feeling mind for me to help you with this problem? Is it all right for you to know why you have this condition? Why it is solving a problem for you? And when I count to 3, the problem will come to your mind, and the way that it is affecting you will be made clear. Well, if it isn't made totally clear,
Yeah.
then the subconscious mind is telling you something that something has to be done. For instance, in a case like that, when you have partial awareness, you could invite the person in hypnosis to go. This is the Wahlberg technique, the theater technique, where you have the patient view a film, and the protagonist is the patient, but for the film, the emotions for the part of the patient have been tuned down. The patient can see the action without an emotional reaction.
Right.
And then that may prove to be efficacious in as much as it will diminish the impact of the trauma without having the patient to be cognitively aware of what has happened. We're operating without the full spectrum, and that allows the person greater confidence and greater latitude,
right,
to see more than they could see if you push the issue without providing that filter. Always have a filter to filter this is the days of implosion therapy are over, where the person is pushed from the deep end of the pool.
Like what cognitive psychologists refer to as flooding.
Yeah, well,
behaviorists refer to as flooding.
Yeah, but the interesting thing is that behaviorists, when they have a problem, they come to us. they don't go to a person who's going to impose flooding on them. I like to see them react to being shoved into the deep part of the water.
Right. Let's see. The follow-up to these questions was what would be the next steps in treatment if after a long period of ideomotor questioning there was no onset that needed to be reframed? To further clarify, what would you do if there was no specific onset of the symptoms that caused the flare-ups?
No precipitant, no.
She said, for example, in the first case, it was his father's admonishment.
Right. So what is the question? What if there wasn't?
What if there was no onset that needed to be reframed, and what would you do if there was no specific onset of the symptoms that caused the flare-ups?
Then we would be after symptom reduction. There's no insight necessary. Look, we can credit ourselves above and beyond what we do, and we can attempt to make our methods to be superior to the behaviors. But the reality is that there are patients who respond very well to more dramatic and more sudden exposure. Others need more tentative, more cautious, and more protected approach. If a gentleman had indicated that there was no archaeological material to dredge up, then we would have detoured right there, and then proceeded to a more direct model, more direct direct suggestion under hypnosis. If there's no reaction, no untoward reaction, then he's indicating to us that he's capable of. He's older now, and he's more mature. He's got greater resources,
Right.
so he can tolerate a more direct and less veiled approach.
So that response is indicative of his readiness and his ego strength to be able to be a candidate for direct
That's great.
direct suggestions.
Yeah. When you ask him, is it all right with your deepest feeling mind for me to help you with this problem? Well, that's getting at the function of the symptom, the purpose, the part that it plays in the functioning of the individual. If you have a person with adaptive surplus adaptive coping mechanism, then he would probably say, "It is all right for you to help me with this problem. It is all right."
Yeah. Anything that the students didn't ask that you wanted to be able to speak to, or that you wanted to be able to say?
Well, there's always a reality that you're not gonna reach a status of being successful in every case.
Right.
I had a gentleman that I was seeing for insomnia, and during his first initial 10 visits, he did very well. He was sleeping, but then something happened, which is still perplexes me. Something happened that he remitted, and he went back to the primary concern. He was not sleeping.
Yeah.
We tried a number of things. I ended up referring him to a sleep clinic. You have to know when to realize that there are other reasons beyond your own world, and you have to resort to doing a good referral.
What helped you to arrive to the decision point to refer as opposed to continue to treat?
I was convinced that he would come back again, and I could help him reach a resolution of the initial complaint. But after a few sessions, the patient was getting frustrated, and we were not operating in a fashion that would be suitable for him to acquire results even down the line. So the most responsible method, means here was to send him to a sleep clinic.
Yeah.
He hasn't come back, so he must have done very well with the clinic's approach.
So it sounds like there was the treatment approach, the therapeutic relationship, and even the sense of mystery in terms of what was going on with him that informed
Yeah,
how to proceed.
and you have to give the due importance to all of them, and not
Yeah.
just get seduced into pursuing
Right.
the most mysterious, the most esoteric,
Yeah.
because then your orientation is for your curiosity,
Right. Right.
and not for the patient's
Yeah.
well-being.
Good way to conclude. On behalf of the students, we're deeply thankful and appreciative of your presence today, Dad.
Call me anytime. I'm partially retired, so I'd be happy to do it. Thank you.
All right, guys. Be safe.